folks, I'd like to say a few words about abnormal behavior. And, this is, of course, a major part of the topic of clinical psychology, diagnosing and treating abnormal behavior. And there's a famous and important volume called the Diagnostic and Statistical Manual of Mental Disorders that we abbreviate as the DSM. And it's published by the American Psychiatric Association, not the American Psychological Association, but the American Psychiatric Association. It was started to be published in, I believe, 1952. And then the current one is the DSM-5 TR, right? So in other words, we can refer to the DSM as the general publication, but it does become revised periodically as changes are made. In other words, as it's kind of an evolving document as we gain understanding of different disorders. So whenever you see the term DSM, it means Diagnostic and Statistical Manual. What it will do is it will provide insight to clinical psychologists as they receive symptoms from a patient or client. And based on those symptoms and other diagnostic and statistical criteria, such as the age of the patient, the gender, recent stresses the person has been through. In other words, it's kind of a cookbook formula. In other words, based on the information the clinical psychologist receives, then there can be a diagnosis made. So and all of the currently recognized psychological disorders are listed in the DSM. So it's considered kind of the clinician's Bible. So what is abnormal behavior? Well, abnormal behavior refers to many ways of defining abnormal. It can be abnormally good or abnormally maladaptive. So in other words, statistically unusual. But we would say that if there's a condition that a patient has, an individual has, that they cannot control, and that somehow interferes with their ability to live a functionally adaptive, a relatively happy life, then it may be a diagnosable disorder. And so, there's a number of terms that we want to mention. One is the maladaptive view. In other words, the maladaptive view of abnormal behavior would be that if there's some kind of a condition that prevents somebody from performing their daily activities. It could be depression, it could be a mood disorder, it could be an anxiety disorder, whatever it happens to be, then maybe it's a diagnosable disorder. It causes distress, and people can be diagnosed with more than one disorder. Those would be comorbidities. So in other words, somebody could have an anxiety disorder along with a mood disorder, but the idea is that one of them is going to be the primary diagnosis. So in other words, in order to provide treatment, you have to have some kind of a basis, some kind of a starting point. And today we use what's called the biopsychosocial model of mental illness or maladaptive behavior, which basically says it's kind of a combination of biological and psychological and social factors. In other words, we know that many disorders have kind of a genetic vulnerability that somebody inherits. That'd be the bio part, and also any aspect of the condition that is reflected in biological factors, such as we know brain chemistry can have a strong impact on disorders. So that'd be part of the bio part of the biopsychosocial model. With the psycho part, in other words, psychological aspect would be, current stresses the person has, and in other words, kind of personal aspects of the disorder. And then the social model would say that, well, gee, sometimes there are social factors that can have an impact on vulnerability. In other words, for example, living in a high crime area of a city produces its own set of stresses, and being unemployed, in other words, in a region that has high unemployment or something like that. So things in society. In other words, there are certain members of society that may be the target of prejudice and discrimination. So there are, so we'd say that the occurrence of a disorder is kind of in a sense, a combination a confluence of biological factors, psychological factors, and also social factors. So, and there's quite a variety of mental illnesses that have been identified and defined as the as the DSM has evolved. We've gained more insights, and in other words, different categories of mental illnesses can be collapsed and into one. In other words, the way we categorize mental illnesses today may be a little bit differently than we did years ago, or we will in the future, based on new information that comes in. The history of mental illness, of course, mental illness has been around for as long as long as humans have. And people have had different views of how to treat mental illnesses and different views of the illness itself. Trepanation was an early type of treatment for mental illness, in which people would actually have holes drilled in the skull to let out evil spirits. In other words, people had a psychological view, or I should say a supernatural view, that says that if somebody has a mental illness, it's probably due to supernatural factors. It's demon possession, or some kind of spiritual influence going on there. So drill a hole in the skull, and that can provide an escape route for the spirit that's taken over the person. And of course, that gets more into the area of treatment, which is a different topic. There was an important movement that began around the 1790s that said that. And these are three important names: Pinel, Rush, and Dix, Dorothea Dix. Philippe Pinel is known for kind of promoting the humane treatment of mentally ill individuals in France, in Paris, France. This would be around around the 1790s. So in other words, he's a famous doctor, medical doctor, and and at the time, mentally ill patients were held in very kind of unsavory conditions. In other words, they were treated as if they're criminals. So Pinel said, well, geez, they shouldn't be treated as criminals. They should be acknowledged as individuals that have what's called a mental illness. And since that time, of course, the 1790, and then 100 years later, right? In other words, there's been a lot of interest in this area, but in the 1890s, Sigmund Freud in Vienna, Austria, promoted his new basis for diagnosing and treating mental disorders. In other words, he had his own view of what causes mental disorders. Of course, he was known for emphasizing the role of unconscious factors in childhood events that would later show up in an adult as mental illnesses. But he really had the first system of treatment that we call the psychoanalysis, or the psychodynamic approach to mental disorders. So we'd say that since the 1790s, there's been a lot of progress made in not only identifying different kinds of mental disorders, but also in promoting the use of good treatment regimens for them. One of the categories of mental disorders is called neurodevelopmental disorders, which refers to the idea that they happen when the development of the nervous system. A couple of examples of neurodevelopmental disorders would be ADHD and ASD, autism spectrum disorder, and attention deficit hyperactivity syndrome, and then a mild form of autism called Asperger's syndrome, which these are indicated by symptoms like children that have difficulty, usually in children, right? And they have difficulty focusing on things, for example, in a classroom, easily distracted. So that'd be ADHD. Attention deficit, which means difficulty, keeping attention on one item. Hyperactivity disorder. So in other words, people are, very fidgety and unwilling, or I should say, basically unable to focus well on topics at hand. Autism spectrum disorder. Autism is a condition where people, again, mainly diagnosed in children, as far as I know, but it can continue into adulthood, in which people have like difficulty forming close social relationships with other people in their families, that kind of thing. autism means kind of a focus on the self. So in other words, they're unwilling to respond appropriately, or I say unable, basically, to respond appropriately to tender, caregiving by people that are taking care of them. They're both of these conditions seem to have a genetic component. As we know, the stress diathesis model of mental illness says that there's a stress that can have an impact on genetics. In other words, if you have the genetics for something, then a stress can trigger the disease. Sometimes the disorder, we say the disease and disorder are interchangeable concepts. So there seems to be a genetic component to a lot of the disorders. Not necessarily all, but perhaps many of them that have been identified. Anxiety disorders are psychological disturbances marked by irrational fears, often of everyday objects and situations. Some of this material is from your textbook, including generalized anxiety disorder, panic disorder. In other words, people have a kind of a long-standing tendency to have anxiety as a large part of their life for a number of months. Panic disorders, these are all, notice they're all types of anxiety disorders. In other words, what is anxiety? Anxiety is like an irrational fear of something. In other words, a fear that doesn't seem to have a strong basis in reality. Panic disorder would be a situation where people have often unpredictable what's called panic attacks. In other words, kind of the fight, flight, fright reaction, or the stress reaction kind of overtakes the individual, often without warning. Sometimes it happens in some situations more than others. In other words, maybe the person will have a tendency to have panic attacks maybe on the subway, or in particular kinds of situations. Phobias, as we know, are irrational fears of particular objects or situations. Right? Those are phobias. People have often phobias are linked to objects like small animals. Those are called simple phobias. And other phobias would include things like social phobias and agoraphobia. OCD is we can say, okay, OCD, obsessive compulsive disorder, where people have an obsession is a thought. In other words, a thought that you can't get rid of. An unfavorable set of ideas that kind of overtakes the person. And then a compulsion is a behavior. So the idea is there's some kind of a linkage there. So when somebody has this obsession, then by doing a behavior, the obsession goes away temporarily. So in other words, there are like compulsions include things like hand washing, and people that perform repetitive behaviors many times more than is logically necessary. Post-traumatic stress disorders are disorders, and post-traumatic stress disorder, right? It would be a disorder where people have an event, which is a traumatic circumstance. It could be, it doesn't have to be. It could be in a battle situation in warfare. It doesn't have to be. It could be a personal, physical attack, sexual molestation, anything that is personally very traumatic to the individual, and then the person kind of varies the reaction, his or her reaction to it. And then the reaction of anxiety linked reactions, it may show up as depression or other kinds of symptoms. They can show up hours, days, weeks, even years later. In other words, because the person has repressed their original reaction, their emotional reaction to the traumatic event. That's the post-traumatic, right? So another after a trauma has happened. I would think that in May 2022 in Uvalde, Texas, the school shooting victims and their, and people that knew them and their parents would experience a lot of PTSD. Will probably show up maybe after weeks, months, and years later in parents and surviving students. In other words, when people had underwent a traumatic event, whenever there's a traumatic event, in other words, there could be a hurricane, Years ago, there's floods and hurricanes in New Orleans or different parts of the world where massive numbers of people are exposed to traumatic circumstances. Well, they may be fine until, could be, as I said, months, even years later, and it can show up, in which people are able to show symptoms of, and how it shows up in somebody it kind of varies from person to person. In this person, it may show up as anxiety. Another person may show up as a mood disorder like depression. Another type of, we'd say, an anxiety-linked disorder is a dissociative disorder. Involve the disruptions or breakdowns of memory, awareness, and identity. Include dissociative amnesia, dissociative fugue. Fugue is like when people have loss of awareness of who they are, and in other words, they may find themselves in a particular location and kind of lose track of who they are, where they live, that kind of thing. And dissociative identity disorder would be where people can actually have a number of different personalities within them. It used to be called multiple personality disorder. In other words, people can have dozens of personalities within them. In other words, on that, but there's always going to be kind of a designated, home personality, right? Where the person may be very, very genuine, and then they kind of split off and they move into these other personalities without an awareness of each other. And so we think it's often linked to some kind of trauma that happened perhaps in childhood. In other words, there can be very distinct personalities. In other words, one of the personalities is really good at playing the piano or math, but another personality doesn't know how to play the piano. All kinds of very unusual symptoms that can happen. If somebody was sexually molested at an early age, maybe the age of 10 years old, 11, 12, that may show up later in a personality that may be, in other words, the individual is a big partier and maybe sexually promiscuous later in life, but that'd be an alternate personality. In other words, the person that experienced the actual trauma kind of buried it, the experience, repressed it, and then it can show up in a different kind of personality. But I think, as far as I know, most psychologists would say that there's a lot of linkage with things like sexual molestation and repressed memories that people have. Mood disorders include, again, written here, the person's mood negatively influences his or her physical, perceptual, social, and cognitive processes, including dysthymia, which is a kind of not a major depressive disorder, but maybe a little bit less severe. But still, if somebody has dysthymia, it means they have depression. It does affect their life in a negative fashion, but it's not totally incapacitating. Major depressive disorder would include, depression. Depression is a mood disorder where people feel hopeless and helpless. Right. So in other words, a major depressive disorder would be a very strong feeling of it can become suicidal. A person feels, use those two terms, hopeless and helpless, just doesn't see a way out of the negative mood. Bipolar disorder would be a situation where people have what are called extreme mood swings, and the mood swing is from mania on one end to depression on the other end. So think of a mood. Everybody has moods, right? And normal people can have a mood. They feel very happy one day, and maybe they're a little bit down. But notice that's not a wide range. But people that have extreme mood swings, in other words, they can become very depressive, maybe suicidally depressive, because of the disease. This disease here that we're talking about. And then gradually they may go through periods of normalcy, and then they'd move to the other end of the spectrum, and they would show kind of a manic mania, manic behavior, such as often involving things like abnormal reckless driving through town, and maybe sexual promiscuity and excessive levels of energy. People will decide to I'm going to write a symphony today or something. In other words, have very abnormal kinds of engage in abnormal kinds of projects, that kind of thing, that are not realistic for the individual. Decreased need for sleep. People can live on 4 hours of sleep a night is fine during that manic phase, which may last several days. Fast speaking, and then so that's the manic phase of manic depressive disorder. So if we say a mood swing, right? In other words, the person actually moves between extreme depression, perhaps suicidal depression, and then within hours or days can swing back into the manic depressive, into the manic, the manic part, and then with periods of normalcy, for a period of time, maybe days and weeks, they're fine, perfectly normal. But that's the bipolar disorder. You see why it's called bipolar? There's two poles. One pole is depression. The other pole is mania, right? So those are all considered mood disorders. A mood is a prolonged emotion, right? So so anything related to those moods as the primary symptom would be a mood disorder. Another type of disorder is schizophrenic disorders. Schizophrenic disorder or schizophrenia, a serious psychological disorder. It is a psychotic disorder in which people have kind of a break with reality, marked by delusions, hallucinations, loss of contact with reality. Again, there's a kind of a listing here. Inappropriate affect means inappropriate emotional reactions, giggling when there should be sadness. Just very inappropriate. Disorganized speech, speaking doesn't make sense to other people. Social withdrawal, deterioration of adaptive behavior. A delusion is a belief system. In other words, people can have the delusion that maybe they're the reincarnation of Napoleon Bonaparte, or the delusion that they're being sought after by the FBI or the CIA or something like that. See that man standing outside my house? He's with the CIA, and he's trying to track me. That kind of thing. In other words, belief. It's a belief system, and often it's like, well, my brain has been controlled by computer chips, or people. I took the COVID injection. And I think they're going to have there's a computer chip in there that's going to mess with my DNA or something. It's a belief system that people have that can't be disproven to them. Hallucination, on the other hand, would be a perception, an abnormal perception. In other words, hearing sounds, hearing voices, music. Most hallucinations, as far as I know, are auditory. They can be visual. They can be any sensory kind of experience. In other words, seeing things that are literally not there, or hearing noises, hearing things that are, that normal, non-schizophrenic people cannot experience because of the disease. So we say delusions and hallucinations are they happen in schizophrenic disorders, but they're different things. Delusions are belief systems. Hallucinations would be sensory experiences that people have. 5 types of disorders, and 5 types of schizophrenic disorders here. Paranoid schizophrenia. In other words, paranoid schizophrenic disorder would be where people have hallucinations and delusions of like often of being, feeling really special and grand, and having the view that people are trying to kill them because maybe they see themselves as, as Jesus Christ, or as some kind of important historical person that people are going to kill again because they did before. Catatonic schizophrenic illness would be unusual motor activity, extreme negative vision, peculiar posturing. In other words, where people kind of they kind of go back and forth between extreme restlessness and moving around, and then they can assume statue-like positions, as if, in other words, they just kind of stop moving. And they can actually maintain the same, posture for hours, maybe days. Disorganized schizophrenic illness used to be called hebephrenic. Or disorganized would be the type of the most, as far as I know, the most difficult to expect recovery from. It's like kind of a total loss of contact with reality. Flat affect. A flat affect in psychology means no emotional reactions at all. Undifferentiated schizophrenic illness, which would be the kind that has more than one type symptoms from more than one of the others. In other words, aspects of paranoid, catatonic, and and disorganized. So that's called undifferentiated schizophrenic illness. In other words, not clearly one of the other types. And then residual would be a residue, right? In other words, residual schizophrenic illness means that somebody has had schizophrenic illness, we'd say, has experienced full-blown symptoms, and yet now their main symptoms have gone away. But there's a little bit of, residue. In other words, maybe they're kind of giggly, they're kind of odd, eccentric people, but they're okay. They're not dangerous to themselves or other people. So they're kind of, they're coming out of it. The thing about schizophrenic illness, at least one of the things about schizophrenic illness is that when people have schizophrenic illness, they tend to recover, So if somebody has schizophrenic illness, diagnosed for it, by it, with it, right? And we know it's strongly genetically influenced. If one parent or two parents have it, one parent has schizophrenic illness, the chances of an offspring having it are greater than if a parent doesn't have it. And if two parents have it, well, then the chances are even greater. So it does seem to have that strong genetic starting point. It doesn't mean somebody is born schizophrenic. It means they're born with the vulnerability, and it may be triggered by a particular life stress. That's schizophrenic illness. We call it a psychotic disorder, where people have a break with reality. And then wanted to mention positive and negative symptoms of schizophrenic illness. Positive symptoms are things that are there in the illness, but they shouldn't be there, such as hallucinations are not supposed to be there, but they are there. Right? That's why they're called positive symptoms. It doesn't mean they're good. It means that they're present, but they shouldn't be. Negative symptoms would be lack of normal behavior, such as a lack of emotional reaction. That would be a negative symptom of schizophrenic illness. So there's various kinds of symptoms. Personality disorders. Another major class of psychological disorders would be indicated by people that have, kind of deeply ingrained maladaptive behaviors kind of built into their personality. We're not sure why they happen. They tend to show up, as far as I know, around the age of 12 years old. People seem, in other words, they have a disorder that causes them to behave in a certain way that doesn't work well for them, although you can adapt yourself to it in your life. Schizoid personality, for example, is a type of personality disorder where people tend to shy away from interactions with other people. In other words, they don't enjoy interacting with people. They're more than just introverts. They're just very, very dissociated from society, that kind of thing. Now, maybe they'll do okay in their life if they take a solitary occupation. I think of something like maybe a lighthouse keeper, somebody that has to spend a lot of time by themselves. Maybe somebody in a scientific laboratory that doesn't require a lot of interaction with other people, and they'd be fine. But they would not be able to form, in general, they'd have a difficult time forming close, like intimate, close emotional bonds with other people. That's one type of personality disorder. Paranoid personality disorder is one that occurs more in males, incidentally. Paranoid does, in which people have like an abnormal suspiciousness of people. They think that people are kind of always trying to trip them up. And they, when they come into a situation, they always have to know who's in charge. They're really keenly aware of power and rank systems wherever they are. So there's a number of different personality disorders. Those are two that are on the list. And those are a few of the disorders in DSM. The somatic disorders are ones that have like physical complaints without physical reasons that can be identified. Freud was very famous for studying somatic disorders. Conversion disorder. where people have physical symptoms that may be related to some kind of a life event in their life earlier. And then so there factitious disorders are ones in which people are able to, they show the tendency to seek lots of extra medical treatment because possibly because they enjoy the reinforcement, they enjoy the attention they have. So they'll have severe headaches all the time, or they'll have pain in their shoulder, something that in other words, the medical people can't really find a physical cause going on there, but there's some kind of a need the person has to seek out medical treatments. And there are sexual disorders, right? In other words, disorders of sexual functioning, unusual aspects of sexual functioning. And so, so that's kind of a broad overview of many of the disorders that are identified by in the DSM. So think of the DSM as the basic kind of the clinician's guidebook. And why is it called statistical? Well, it's called statistical because it's able to identify different like what's the probability if somebody is a 45-year-old female. What's the probability that she presents to a clinician with these symptoms and well, maybe it's a major depressive disorder, or maybe it's a phobia. So that's the statistical part. So those are a few words about abnormal behavior. Good.